Good morning. In today's class, we will be discussing the pharmacology of the remaining non-steroidal anti-inflammatory drugs. In the previous class, we discussed aspirin, the mechanism of action, namely select COX-2 and COX-1 inhibition, its adverse effects, uses. We will now look at how the other NSAIDs mainly differ from aspirin. The first drug we are taking up today is paracetamol. It's also called acetaminophen in the United States. The mechanism of action of paracetamol is similar to aspirin in that it inhibits both cyclooxygenase 1 and cyclooxygenase 2. Paracetamol does not have any effect on platelets. Now, compared to aspirin, paracetamol has analgesic and antipyretic activity with very poor anti-inflammatory and antiplatelet action. Paracetamol has very weak anti-inflammatory activity because at the site of inflammation, the peroxides present inactivate paracetamol. This is a short answer question. Meaning, give reason, paracetamol is not a good anti-inflammatory drug. It has no antiplatelet activity. When administered orally, paracetamol is well absorbed and is glutathione conjugated in the liver. As you know, glutathione is a tripeptide comprising of gamma-glutamyl cystinyl glycine. Paracetamol has a plasma half-life of 4 hours, therefore needs to be given every 4 hours or 6 times a day. The usual adult dose of paracetamol is 650 milligrams tablets and is used for mild to moderate pain like toothache, joint pain, myalgia, etc. and also as an antipyretic to reduce increased body temperature. Adverse effects of paracetamol include hepatotoxicity, especially in large doses, methemoglobinemia, hemolytic anemia, allergic skin reactions, nausea, vomiting, diarrhea, and with long-term use, nephrotoxicity. Coming to the mechanism of the hepatotoxic adverse effect of paracetamol. The phase 1 metabolite of paracetamol is N-acetyl parabenzoquinone. Now this hepatotoxic phase 1 metabolite is quickly detoxified in the liver by conjugating with glutathione. So in paracetamol overdose, the antidote is N-acetylcysteine, which is given intravenous. Now cysteine, sulfur-containing amino acid, rapidly replenishes the hepatic glutathione stores. This again is a short answer question. Name the antidote for paracetamol overdose. Or the other sulfur-containing amino acid, methionine, can be given orally in paracetamol overdose. A frequently asked 2-mark question is, what are the advantages of aspirin? What are the advantages of paracetamol over aspirin? Lesser gastrointestinal adverse effects like gastritis and peptic ulcer. Paracetamol is safe in children because it does not cause Reye's syndrome. Paracetamol does not have any effect on platelets. It does not have any effect on the acid-base balance, and even in case of overdose, the specific antidotes N-acetylcysteine and methionine are available. These are the advantages of paracetamol over aspirin. Now coming to these two drugs, phenylbutazone and oxyphenbutazone, once upon a time they were quite popular anti-inflammatory drugs. But as of today, phenylbutazone and oxyphenbutazone are used specifically in acute gout, rheumatoid arthritis and ankylosing spondylitis when other drugs do not produce any relief. Now why this specific limitation is because both phenylbutazone and oxyphenbutazone cause agranulocytosis, which is a potentially fatal toxicity. Therefore, phenylbutazone and oxyphenbutazone, though they are very good anti-inflammatory drugs, their use is restricted because of this potentially fatal agranulocytosis. Coming to the propionic acid derivatives, as a group, these drugs are better tolerated than aspirin, especially the gastrointestinal adverse effects. Ibuprofen is equipotent as aspirin and is used as an analgesic, anti-inflammatory and antipyretic drug. So the mechanism of action of the propionic acid derivatives is similar to aspirin, namely inhibition of cyclooxygenase 1 and 2. Adverse effects of the propionic acid derivative group includes agranulocytosis, visual disturbances, peripheral edema, especially of the ankles, hepatitis and nephrotoxicity with long-term use. Flurbiprofen is more potent than ibuprofen, and flurbiprofen was the first non-steroidal anti-inflammatory drug for use in ophthalmology. Ibuprofen and flurbiprofen are used for musculoskeletal pain of all types, pain associated with trauma, osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, dysmenorrhea, toothache and post-operative pain. Diclofenac sodium and its potassium salt, diclofenac potassium. The difference here between these two is the potassium salt is rapidly absorbed on oral administration, therefore has a quicker onset of action. Mechanism of action of diclofenac, like aspirin, inhibition of cyclooxygenase 1, cyclooxygenase 2, therefore no prostaglandin production or decrease in prostaglandin production. Diclofenac sodium, diclofenac potassium are among the more potent of the non-steroidal anti-inflammatory drugs. In addition, diclofenac reduces intracellular concentration of arachidonic acid in leukocytes, inhibits neutrophil chemotaxis and superoxide formation at the site of inflammation. And a very important pharmacokinetic property of diclofenac is it gets concentrated in the synovial fluid, making it the drug of choice for all kinds of arthritis. So this again is a short answer question. Give reason diclofenac is preferred in arthritis. The reason being it gets concentrated in the synovial fluid. Diclofenac is available as tablets, injection for intramuscular use and also as a topical gel. Adverse effects of diclofenac include allergic skin reactions, nausea, vomiting, diarrhea, peripheral edema and very rarely blood dyscracias. Diclofenac is used for relieving pain of musculoskeletal origin of all types, pain associated with trauma, osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, all types of arthritis, toothache, post-operative pain and in acute gout. Aceclofenac is related to diclofenac and compared to diclofenac is relatively selective for cyclooxygenase 1, therefore lesser incidence of gastrointestinal upset. Aceclofenac may have chondroprotective activity by stimulating glycosaminoglycan synthesis, especially in the joints, making it again a drug of choice for all types of arthritis. The other properties, including adverse effects, are similar to diclofenac. Now, ketorolac is important, especially in treating intra and post-operative pain. It is a potent analgesic and anti-inflammatory, antipyretic, with weak anti-inflammatory activity. Adverse effects of ketorolac include gastrointestinal upset, dizziness and skin rashes. The importance of ketorolac is, like we mentioned, in treating post-operative pain and severe acute pain. For severe acute pain, opioids are generally used, but when ketorolac is administered before an opioid, the dose of opioid required is decreased. This is referred to as opioid sparing effect. Ketorolac is available as tablets for oral administration, injection for intramuscular intravenous use and as eye drops. Etodolac is similar to diclofenac with moderately selective inhibition of cyclooxygenase 2. Oxicams again are a new group of non-steroidal anti-inflammatory drugs which are either preferential or selective cyclooxygenase 2 inhibitors. Piroxicam and tenoxicam inhibit both cyclooxygenase 1 and cyclooxygenase 2. Meloxicam is a preferential COX-2 inhibitor. Adverse effects of the entire oxicams include gastrointestinal upset, skin rash, tinnitus and peripheral edema. The oxicams are used in the treatment of acute gout, post-operative pain, dysmenorrhea, osteoarthritis, rheumatoid arthritis and ankylosing spondylitis. Meloxicam is, as of today, used in the treatment of osteoarthritis, rheumatoid arthritis and ankylosing spondylitis. Nimesulide is a frequently appearing 5-mark question because it has multiple mechanisms of action. 1. It inhibits cyclooxygenase 1 and cyclooxygenase 2. It is similar to aspirin in this respect. Nimesulide inhibits histamine release from basophils, decreases superoxide anion formation. Nimesulide scavenges free radicals at the site of inflammation and inhibits platelet activating factor synthesis and the release of tumor necrosis factor alpha. Also inhibits metalloproteinase activity in the cartilage. So compared to aspirin, Nimesulide has multiple mechanisms of action, and you can notice that almost all the inflammatory processes are decreased. A point to note about the adverse effects of Nimesulide is it is hepatotoxic and nephrotoxic in children. Therefore, Nimesulide should not be used in children. What was the reason for aspirin not being used in children? Yes, it causes Reye's syndrome. Other adverse effects of Nimesulide include gastrointestinal upset, dizziness and skin rash. Nimesulide is used in adults for treating pain of musculoskeletal origin, toothache, headache, myalgia, etc. Nefopam is a drug which has only analgesic activity. It does not have anti-inflammatory, antipyretic or antiplatelet activity. Nor does Nefopam have any action on cyclooxygenase. So the mechanism of action as an anti-inflammatory of Nefopam, as an analgesic of Nefopam is quite unique. That is, it inhibits the reuptake in the brain of these neurotransmitters, namely dopamine, noradrenaline and serotonin. So please note, Nefopam does not have any action on cyclooxygenase or on the opioid receptors. Adverse effects include gastrointestinal upset, palpitation, nervousness, convulsions and dry mouth. So the uses of Nefopam, if you notice, it does not act via cyclooxygenase nor the opioid receptors. So Nefopam is used in patients who are suffering from pain, mild to moderate pain, who are allergic to the other NSAIDs and in opioid addicts. Nefopam should not be used in patients who are taking monoamine oxidase inhibitors, because Nefopam inhibits dopamine, noradrenaline and serotonin reuptake. This can result in a hypertensive crisis. Now coming to the selective cyclooxygenase 2 inhibitors, as is marked here, is a 5-mark question. These are called the Coxibs. Celecoxib, Etoricoxib and PARACETAMOL are available in India. Lumaricoxib is available in Europe. Rofecoxib and Valdecoxib have been withdrawn because an increase in cardiovascular events like arrhythmias, myocardial infarction was noticed. Now, because the Coxibs are selective cyclooxygenase 2 inhibitors, they are less likely to cause gastric damage and inhibit platelet aggregation. Adverse effects, though we say less likely, it does cause some amount of nausea, vomiting, gastritis, skin rash and peripheral edema. The Coxibs are used in acute gout, postoperative pain, dysmenorrhea, osteoarthritis, rheumatoid arthritis and ankylosing spondylitis. Indomethacin is a drug belonging to the NSAID group, which is more toxic than aspirin. So whatever adverse effects we mentioned for aspirin, under the gastrointestinal tract, respiratory system, acid-base balance, Rice syndrome, bleeding, everything is more with indomethacin. In addition to that, indomethacin can cause confusion, a very rare but severe form of Stevens-Johnson syndrome, bone marrow depression, hypersensitivity and confusion. Because of this adverse effect profile, the use of indomethacin is very restricted. Indomethacin is used in osteoarthritis, rheumatoid arthritis, pericarditis, pleurisy, and to close patent ductus arteriosus in premature infants. Indomethacin is also available as an eye ointment. A frequently appearing compare and contrast question is compare and contrast aspirin and paracetamol, which need to be discussed under the following heads: the chemistry, mechanism of action, effects, uses, adverse drug reactions, and in case of overdose, is there an antidote available? Thank you.